Hello students, today's class is about second adrenocortical hormone, that is mineralocorticoid, and the main mineralocorticoid is aldosterone, which accounts for about 90% of all mineralocorticoids. Others are deoxycorticosterone, corticosterone, cortisol has also some mineralocorticoid activity. So aldosterone, first we will discuss about mechanism of action of mineralocorticoids. So aldosterone diffuses readily to the interior of the renal tubular epithelial cells because of lipid solubility in the cell membrane. In the cytoplasm, aldosterone combines with a highly specific cytoplasmic mineralocorticoid receptor protein, MR protein. The aldosterone receptor complex, or a product of this complex, diffuses into the nucleus, inducing one or more specific portions of DNA to form one or more types of messenger RNA related to the process of sodium and potassium transport. The messenger RNA diffuses back into the cytoplasm, where, operating in conjunction with the ribosomes, it causes protein formation. The proteins formed are mixtures of one or more enzymes as sodium potassium ATPase and few membrane transport proteins, as for example epithelial sodium channels, ENaC. Although renal tubular epithelial cell MR receptors also have high affinity for cortisol, the enzyme 11-beta hydroxysteroid dehydrogenase 2 normally converts most of the cortisol to cortisone, which does not readily bind to MR receptors, permitting the endogenous ligand aldosterone to bind to the mineralocorticoid receptors. So now what are the effects of mineralocorticoids? Aldosterone increases reabsorption of sodium and simultaneously increases secretion of potassium by renal tubular epithelial cells, especially in the principal cells of the collecting tubules and to lesser extent in the distal tubules and collecting ducts. Therefore, aldosterone causes sodium to be conserved in the extracellular fluid while increasing potassium excretion in the urine. Excess aldosterone increases extracellular fluid volume and arterial pressure, but has only a small effect on plasma sodium concentrations. Excess aldosterone causes hypokalemia and muscle weakness, whereas aldosterone deficiency causes hyperkalemia and cardiac toxicity. Aldosterone also stimulates sodium and potassium transport in sweat glands, salivary glands, and intestinal epithelial cells, as it is in renal tubular cells. So how does it regulate it? Mainly the following four factors are known to play essential roles in the regulation of aldosterone. These are increased potassium ion concentration, increased angiotensin II concentration, increased sodium ion concentration, and anterior pituitary hormone ACTH. So this is renin, angiotensin, aldosterone system, which regulates mineralocorticoid secretion. So mineralocorticoid production is controlled by the renin, angiotensin, aldosterone regulatory cycle, which is initiated by release of renin from the juxtaglomerular cells in the kidney, resulting in cleavage of angiotensinogen to angiotensin 1 in the liver. Angiotensin converting enzyme cleaves angiotensin 1 to angiotensin 2, which binds and activates the angiotensin 2 receptor type 1, resulting in increased adrenal aldosterone production and vasoconstriction. Aldosterone enhances sodium retention and potassium excretion and increases the arterial perfusion pressure, which in turn regulates renin release. Because mineralocorticoid synthesis is primarily under the control of the renin, angiotensin, aldosterone system, hypothalamic pituitary damage does not significantly impact the capacity of the adrenal to synthesize aldosterone. Similar to the hypothalamic pituitary adrenal axis, the assessment of renin, angiotensin, aldosterone system can be used for diagnostic purpose. If mineralocorticoid excess is present, there is a counter-regulatory down-regulation of plasma renin. Conversely, in mineralocorticoid deficiency, plasma renin is markedly increased. So physiologically, oral or IV sodium loading results in suppression of aldosterone, a response that is attenuated or absent in patient with autonomous mineralocorticoid excess. So an acute decline in plasma sodium of about 20 milliequivalent per liter stimulates aldosterone secretion, whereas the plasma potassium level need to increase only 1 milliequivalent per liter to stimulate aldosterone secretion. Increased angiotensin 2 concentration in the extracellular fluid also greatly increases aldosterone secretion. In normal individual, plasma aldosterone concentration increases during the portion of the day that individual is carrying on activities in the upright position. This increase is due to decrease in the rate of secretion of aldosterone from the circulation by the liver and an increase in aldosterone secretion due to postural increase in the renin secretion. Individuals who are confined to bed show a circadian rhythm of aldosterone and renin secretion, with the highest values in the early morning before awakening. ACTH is also necessary for aldosterone secretion. So now control of cortisol secretion. Hypothalamic release of corticotropin releasing hormone occurs in response to endogenous or exogenous stress. So corticotropin releasing hormone stimulates the synthesis and release of ACTH. ACTH is released by the corticotrope cells of the anterior pituitary and acts as the pivotal regulator of adrenal cortisol synthesis, with additional short-term effect on mineralocorticoid and adrenal androgen synthesis. The release of corticotropin releasing hormone and subsequently ACTH occurs in a pulsatile fashion that follows circadian rhythm under the control of the hypothalamus, especially its suprachiasmatic nucleus. So adrenal cortisol secretion exhibits a distinct circadian rhythm, starting to rise in the early morning hours prior to awakening, with peak levels in the morning between 8 to 10 am and low levels in the evening. So hypothalamic pituitary adrenal axis is assessed by a diagnostic test, that is dexamethasone suppression test. Dexamethasone, a potent synthetic glucocorticoid, suppress corticotropin releasing hormone or ACTH by binding hypothalamic pituitary glucocorticoid receptor and results in downregulation of endogenous cortisol synthesis. If cortisol production is autonomous, as in adrenal nodule, ACTH is already suppressed and dexamethasone has little additional effect. If cortisol production is driven by an ACTH producing pituitary adenoma, dexamethasone is ineffective at low doses but usually induces suppression at high doses. If cortisol production is driven by an ectopic source of ACTH, the tumors are usually resistant to dexamethasone suppression. Thus, the dexamethasone suppression test is useful to establish the diagnosis of Cushing's syndrome and to assist with the differential diagnosis of cortisol excess. So the clinical effect of glucocorticoid excess. So Cushing's syndrome is a constellation of clinical features that result from chronic exposure to excess glucocorticoids of any etiology. The disorders can be ACTH dependent, as for example pituitary corticotropic adenoma, ectopic secretion of ACTH by non-pituitary adenoma, non-pituitary tumor, or ACTH independent, as for example adrenocortical adenoma, adrenocortical carcinoma, nodular adrenal hyperplasia, as well as it can be iatrogenic. As for example by administration of exogenous glucocorticoids to treat various inflammatory conditions. So glucocorticoids affect almost all cells of body, and thus signs of cortisol excess impact multiple physiologic systems with upregulation of gluconeogenesis, lipolysis and protein catabolism, causing the most common features. Excess glucocorticoid secretion overcome the ability of 11-beta hydroxysteroid dehydrogenase 2 to rapidly inactivate cortisol to cortisone in the kidney, exerting mineralocorticoid actions that is manifested as diastolic hypertension, hypokalemia and edema. Excess glucocorticoid also interfere with central regulatory system, leading to the suppression of gonadotropins with subsequent hypogonadism and amenorrhea. So what are the features of Cushing's syndrome? It is weight gain, central obesity, rounded face, there is a fat pad on back of the neck, that is buffalo hump, thin and brittle skin, easy bruising, there is osteopenia, osteoporosis, and due to this osteoporosis there might be vertebral fractures, muscle weakness, irritability, emotional lability, depression, poor wound healing, increased susceptibility to infections, and there are multiple stria on abdomen with pendulous abdomen due to deposition of fat. So this is all about adrenocortical hormones. Thank you.